Okay. So next we will be hearing from Dr. Billy Gallagher. He is board certified in family medicine, fellowship trained hospice and palliative medicine, hospice medical director certified, a Idaho native and a Corps veteran. He works in both rural and urban areas in Idaho and Eastern Oregon, providing care in both inpatient and outpatient settings in geriatric, hospice, and palliative medicine. Chief Medical Officer and Ancora Health Services. He's also the Ethics Chair at West Valley Medical Center and credentialed at St. Alphonsus, Boise, Nampa, and the Boise VA Medical Center, and also at West Valley Medical Center. And he will be talking to us today for our professional education about facing the hard conversations, aging, decline, and end of life care.
Good morning. Hello, everyone.
Oh, hello.
Everyone can hear me okay, hopefully.
Yes.
Awesome. So, hello, and thank you for welcoming me to come talk to everybody. This topic today is a bit of a potpourri, kind of the board members and some friends, I think, just sent a bunch of questions they'd like to ask a doctor, and I think you're just going to get a very skewed answer from a hospice and palliative medicine physician who does a little bit of family medicine. And so this is intended to be kind of a Q&A that's unfortunately one-sided just because of the way that this is kind of designed, but I'm happy to answer any questions, share my email, phone number, whatever. Navigating this kind of healthcare world is really difficult to do kind of on your own, and kind of need resources, and that's ultimately my whole world. And what I try and do is just kind of help people navigate healthcare, particularly around the geriatric population, aging adults, partners, etc. So thank you. Without further ado, I will begin. So learning objectives just identify some clinical, ethical, safety considerations as we're caring for our older adults in our lives, and just kind of run through some of those things. The questions are important because when we don't plan, the crisis is kind of always close to follow. If we can ask the right questions or we can start in the right direction, it can save us months, years, weeks, decades of our lives in some situations if we can get down the right path sooner, as opposed to wandering lost and not knowing what direction to do, being stubborn, trying to figure things out on our own. A lot of times doctors, nurses, CNAs, whoever we know who might be in medicine, we ask them questions and they have like one small sliver of how the world is perceived or how it might work for them in their world, and we just often can get misled. And so it's important to have these conversations and think and plan as our nuclear family disintegrates, because we all have to work to keep things afloat. We move across the country from where we grew up, etc. We have to figure these things out on our own now. Whereas before, when we had multi-generational living, when we lived with parents longer, our grandparents were in the home, et cetera, due to kind of resource bringing those things together, we all learn from each other. But now that's really fragmented, and so we have to figure out other places to learn those. And if you haven't gone through one of these situations, it can be really difficult to navigate for sure. So one of the questions was asked is, what is the difference between kind of dementia versus normal aging? And that kind of brought me to the fact that dementia isn't really the preferred term anymore, believe it or not. As physicians are talking about dementia, we're actually kind of using neurocognitive disorder as the primary language now. And that's actually been a long time. Since 2013 is when that changed. And I'm seeing a lot more traction recently. And so now using that, there still are the dementias in the background, but it'd be more kind of the language would be major neurocognitive disorder secondary to Alzheimer's or Parkinson's or a head injury or whatever it might be. It's really speaking about what it is that you can do and what we're seeing from your cognitive ability. And it's, just there's some goals that they had behind that, just kind of precise, less stigmatizing, more stage-based in the continuum, as opposed to you're just labeled as a certain thing, right? And when people get labeled, they really, really hate it. And so ultimately, mild cognitive impairment is like when it's just not impacting their independence yet. And so we can just basically, real simply look at a chart, and you have aging through time, and our years on the x-axis, just kind of, and cognitive function on the y-axis, just like aging is this very slow but subtle thing, whereas major cognitive impairment or dementia, as we get kind of further down the road, this slide would also be a little outdated technically, but it is really, it kind of has this language of like very slow in the beginning with a really long tail. It just kind of goes and goes and goes, and we call it kind of the dwindles down here in this area that can really be slow sometimes. So there's kind of orange flags, there's red flags. Ultimately, kind of this question was, what are those red flags of dementia? When do we need to be intervening was really the main theme of these things. And so, I just want to really emphasize there are lots of different kind of, it's a picture, it's this clinical syndrome that gets lots of little data points and pieces that kind of get added up to tell this story and make this diagnosis. As you are probably likely aware, you probably haven't heard of very many people getting brain biopsies who've been diagnosed with major cognitive impairment or dementia, because that would be really invasive. And so the only really way to do these things is guesswork based on imaging or characterizations or other problems they may have. Ultimately, would just emphasize really important to get worked up if you have someone in your life who's concerned, who you think might have some impairments, because there's a lot of things that can mimic as we go through mood disorders, perception of the world being altered through hearing or vision. Medications can jack people's wagon for sure. Organ dysfunction, vitamin deficiencies, electrolyte derangements, seizures, brain tumors. There's a lot of things that can mimic these, and many of those can be reversible. Unfortunately, the large majority of folks developing these problems won't be reversible, but you kind of want to look and make sure you're not one of those people. This is ultimately a slide from the Alzheimer's Association, basically just kind of reviewing what are some of those differences. They're subtle and small, but it's, basically, is it a bad decision once in a while, missing one payment versus not paying all the bills, forgetting which day it is versus having no idea what the season is, picking the wrong clothes for the wrong season, for example, as opposed to forgetting what word. It's like can't even have a conversation. They're on kind of planet Mars, and you're here on Earth, and it's just not connecting. A lot of times people really withdraw into themselves because they're starting to recognize they have these major deficiencies. And so as opposed to exposing themselves as not knowing what's going on, you'll see them interact less and less with their world because they don't know the answers, and it's scary. And so they avoid those conversations. They parrot, they'll borrow the words that you give them during conversation. Well, it's a nice day outside, right, Mom? And like, yes, it's a nice day, or whatever it might be. Or it's December, right, Mom? Yeah, it's December. So you have to just be cognizant of the information you give them when you're really trying to explore. So when to seek evaluation, ultimately when it starts to impact judgment and safety and function. Testing can do some things, and there's a lot of things that testing can't do, for sure. There's limitations. Ultimately, you're looking for the diagnosis because you're trying to plan. You're not just looking for the diagnosis. Nothing gets solved when you make the diagnosis of dementia. Your whole world just gets rearranged of like, now I know this isn't reversible. Now I know you need to start working on a lot of things to improve outcomes. I think somewhat similar to kind of like being diagnosed with autism or on the spectrum, neurodivergent, whatever that might be, in terms of like some things can improve, some things can't. And this is the new world that we live in, and we need to really kind of optimize this so we can do the best. And at the end of the day, ultimately, the importance for caregiver education, the do's and the don'ts, and getting help with the legal and financial and all those things. And again, I'll just emphasize the absolute first place to go. And you have any questions about any kind of cognitive impairment or your parents and disability, the Alzheimer's Association is just chock full of resources, whether they have actual Alzheimer's or a different form of cognitive impairment, or they're just being difficult. I think there's a million and one resources that you can find on the Alzheimer's Association website. I found it to be exceedingly helpful. So next question was, when do we step in? When do we step in for care or for finances and doing those things? And, that's very subjective. It's risk tolerance that some people want. Autonomy the desire to be autonomous or to have independence drives our elderly patients and our children, if you have young children at home, to do the craziest, unsafe things in the world. But we have to remember that ultimately their priorities are unlikely to be safety, whereas the most important thing to you might be safety. To them, it's being able to do what they want when they want. Again, just kind of like raising a child. They don't perceive danger in the same way, and they just frankly don't care. They would rather, in some instances, die than not have their independence and get to do what they want. And ultimately, I think when you identify these things early on while they still have capacity, is to just figure out as much planning as you can do in terms of for their safety, their functionality, getting documents done, seeing clinicians and estate planners and all these things, because you don't want to run out of time and not be able to make those important arrangements, because there comes a time in which they would not be perceived of having the ability to make those decisions, and then you're kind of up a creek without a paddle for sure. So with all of these documents, like kind of just reviewing is like kind of what documents should we be doing, what kind of things. You all have to have capacity in order to do these things. And so you likely guys in your other presentations have talked about these things. And so I apologize to anyone where this is redundant. You guys have so many videos in your library that it's hard to kind of capture where there are gaps might be. But ultimately, I think we all need reminders of these things anyways. And these all sort of things that we all kick the can down the road. And then we just need lots of reminders. So if you already know all these things, consider another reminder to make sure you've got all your stuff done. But ultimately, the types of power of attorney, there's generally kind of two types. There's a general durable and then a healthcare. So the general durable is all the financial things, whereas the healthcare is kind of who's going to make decisions for me, what things I want, what things I don't want. There's ultimately within the advanced directives component of the healthcare, there's also a living will. And basically the living will is the roadmap for the healthcare proxy or your healthcare power of attorney to follow. It's the things that they need to know. And this is not a legally binding document in any way per se, except for naming your healthcare surrogate. If you tell them you do or don't want certain things in your living will, they ultimately can kind of overrule that. So you got to make sure you're picking someone you can trust. One of the jokes I had heard from an attorney many years ago that's really stuck with me is he said that you have to pick someone who ultimately is going to honor your wishes as your healthcare power of attorney. And he said, I don't want to be kept alive on machines when I come to the end of my life. And therefore, I'm going to choose my wife's boyfriend to be my healthcare power of attorney because I know that SOB wants me dead. And just kind of really emphasizes the point of like, if that's important to you, you really got to pick someone who's going to follow through. These documents are only applicable while you're alive, except for the funeral arrangement component within the healthcare power of attorney. Otherwise, these documents have no power over your belongings or anything after you're gone. The standard will it is often confused with the living will. And so I'm always talking to people about, the standard will is not the living will in terms of like the things, the car, the cat, the dog, the money that you have. And that is one that only takes place after you die, whereas the living will is while you're alive and what healthcare experiences do you want to have on your journey ultimately. And then there's another component, kind of living trust, which it sounds like you guys have a presentation about in a couple of weeks, which ultimately is kind of all geared around making sure it's as organized as possible and avoiding probate, which there's more tax implications, there's more time involved, there's the courts involved. It just gets really messy really fast. The other document is a kind of call these portable orders, physician's order for scope of treatment. You can find this on the Idaho Department of Health and Welfare website. This is technically not an advanced directive, but it's definitely a kissing cousin as far as I'm concerned. It's an actual medical order written and signed by a physician, a physician assistant, a nurse practitioner. It's an actual order for the ambulance drivers, the ER, whoever's going to come across you in terms of, are you wanting heroic measures? Are you not wanting heroic measures? Advanced airways, level of care, where do you want to be? Antibiotics, there's all kinds of little components in there you can kind of fill out. And we talk about a lot with the learners that I teach, the medical residents and the fellows, is basically everybody should probably have a living will. It doesn't matter how old you are. If you want to pick who you want to make decisions for you, you need to do a living will, naming a healthcare power of attorney. In Idaho specifically, there's a very specific statute that says, basically your court-appointed guardian followed by your healthcare power of attorney. And if you don't have either of those, then it becomes your spouse, then it becomes your adult living children, then it becomes your parents, and then your siblings, and it just kind of runs down this specific list. And so if you've got multiple children or you've got multiple parents who are going to maybe not disagree, whatever it might be, you really have to kind of go out of your way to make sure that the living will names who you want. Whereas this document is this is a conversation between the doctor and you and the future people taking care of you. If you've never seen one of these, real briefly, it basically discusses, in the event that you have no pulse or you're not breathing, do you or do you not want CPR? So up there, and then if you're sick but you do have a pulse and you are breathing, where do you want to be taken care of? And so if you're doing the hospice type of scenario situation where you want to be left where you're at and just kept comfortable, versus if you want to go to the hospital but not get heroic measures, is kind of this option. And there's this big fat box you can write in all kinds of preferences. Do definitely make sure you're thinking thoughtfully about some of these things. But if you wanted to limit blood products, dialysis, antibiotics, any type of other heroic kind of interventions that would otherwise be considered kind of beyond nature, kind of taking care of business, so to speak. And then, of course, feeding tubes. Back to the kind of documents, I did mention kind of guardianship, and so I want to just kind of really quickly review the difference between conservatorship versus guardianship. There is really important to note that doctors and the healthcare team, they determine capacity, whereas the courts, which is who establishes conservatorship and guardianship, they're the ones that make the decisions regarding competency. And so very costly, very time intensive. The conservators basically is equivalent to that durable or financial power of attorney in terms of bills and banking and property and all those types of things, whereas the guardianship controls kind of the person and the healthcare and where they live and the safety and all of those types of things. And so they are two distinct things. They can be the same person, but they are ultimately distinct. You may need one, you may need both. It really depends, and that again kind of is ultimately to the healthcare, or excuse me, is decided in the courts. Moving on, again, kind of a potpourri of questions here was, how do I determine if my loved one, whether parent or significant other, is still safe to live alone? And ultimately, it all comes down again to that risk tolerance, safety, function, and support system that they have. Do they have close neighbors? Do you have cameras in the home? Do you have an adult who can still manage a cell phone? Talking about falls, are they able to take their own medications? Are they feeding themselves reliable? Are they isolating themselves and they wouldn't be able to call for help? Home safety assessments can really be helpful. Care management can be helpful. Ultimately, I think, again, talking about the safety and the risk tolerance, kind of the early stage where we're thinking we need a bit more help, is the food in the fridge spoiled? Are they starting to really clutter the home and they're not going to be able to get out in the event of a fire? Are there stacks and stacks of unopened mail and bills that are really gathering and are going to create a financial crisis that it's going to need to be unraveled later? Are they keeping themselves clean and dry? I think a lot of times, with poor peri-care, our elderly females are getting lots of urinary tract infections and other sorts of problems. Is dad still driving? Those types of things in terms of safety and the safety of others. And when those things really start falling apart, kind of more of that, middle and late stage, where then we're talking about, is dad's killing mom because dad needs all of this help and he's not able to do anything? Or is there physical assault that's happening? Just last week in the hospital, I had a gentleman who was described as this son I was talking to, he was my hero. He was just the most amazing guy. Everyone loves him. He was such a kind gentleman, and he is unfortunately getting a pretty advanced stage of what seems to be Alzheimer's dementia. And he in the last year has physically assaulted his wife on multiple occasions, thinking like he's scared. He was trying to
What?
escape. People are trying to hold him back.
I've learned meeting
Um,
uneven in it, Heather.
in the hospital, he's also punching caregivers and putting people in headlocks and all these things. And he was never the type of person to act or do those things. And so just really just identifying, is the person taking care of them safe? Are they safe? Just kind of all those things. Future living arrangements. This is something really important, I think, to talk about in our healthcare documents is like, where do I want to live? Where do I want to be? I think most people want to stay at home as long as they can. In fact, many think they're going to be able to stay home for the rest of their lives. But the reality is that many people are not prepared for this. The thing I'm always repeating is that your health insurance does not want to pay your mortgage, and it doesn't want to buy your groceries. The thing that will pay your mortgage ultimately, right, is long-term care insurance, or if you have Medicaid, or if you have the VA as a secondary, and you have a service-connected condition. But other than those few things, you got to live with family, or you got to have a boatload of money, or you've planned really well. Medicaid, obviously, with the Miller Trust and some things you can leverage, but it's really difficult, and people are just heartbroken when I share with them the costs that these things carry in terms of how much does it cost to live in an assisted living. I have not really seen lately anything less than 4,000 a month, and that's your basic, kind of run down, multiple people in a room type of situation. And then, personal care services, people think I'm just going to hire someone, they're going to come in, and you're talking about minimum, generally speaking, unless you find someone who you're paying under the table, you're talking $30 an hour. If you do the math real quick, if you need 24/7 care, 30 times 24 times 30, the number gets up in the mid 20,000 really quickly. And then if they need skilled nursing care, they need an actual nurse there to be there kind of all the time, and they have to live in a skilled nursing facility versus an assisted living where they're kind of doing the bare bones. You're looking upwards of $8,000 to $12,000 a month. And so I don't know very many people, at least who are born and raised here in Idaho, who kind of didn't really work their butts off to make and gather a lot of resources, or from out of state, one of those wealthier places where they come with kind of a boatload of money. It's really difficult. Sometimes, again, another question was like, when is treatment potentially harmful? What can we do? And so we're always, working through the lens of what is helpful and what is maybe potentially harmful. It's really important to know, especially when we're talking about dementia or major neurocognitive disorder, that really, aside from those reversible conditions early on, there really isn't any medication to date that's making meaningful changes or preventing mortality or preventing institutionalization, meaning needing to reside in a facility. There's those injectable medications that are new, but they're not really shown to do anything. They come with lots of risk. The other medications we have, like the donepezils and the memantines and all of those other medications, they all can show a little bit of benefit in terms of delaying progression to needing to be placed in a facility, usually on the order of months, but very rarely is it every years. Like 18 months is, like, generally speaking, what the medication can do. And again, that just delays the amount of time before they need to be put in a facility to be cared for on a 24/7 kind of basis. Potentially, those medications can reduce a little bit of caregiver burnout, reduce a little bit of the behavior component, but it's really not as much as people are hoping for, certainly as much as the commercials on TV would tell you, right? And there's obviously any medication, if there's a medicine out there that a doctor tries to tell you there's no side effect to, you should just immediately find another doctor. And I don't care if that's a supplement, a complementary treatment, or therapy. Like, it's all at a certain point. Basically anything could be potentially harmful if kind of used and abused. I mean, water, for example, can even be harmful at a certain point, right? And so, and ultimately, as we go through and we're helping folks navigate these things, there's just this growing cumulative impact, impact of hospitalizations and these procedures and these interventions, and just being told time and time again, there's little that we can do, and it just becomes very frustrating and difficult. And so ultimately, working with, your team's palliative care, in this instance, geriatricians, your primary care doctors in more rural settings who don't have access to these extra specialties, through neurologies or whatever it might be, just kind of reviewing what is important and what are the things we want to do and what are the things we don't want to do, because that's what's ultimately going to also help make your life much more manageable if you can make sure that you're doing the things that are important to your loved one. The things that are unhelpful, because I hate to be just completely negative Nancy here. Excuse me if there's anyone named Nancy on here, but this is, one out. Also, just kind of what are the things that can actually be useful and helpful, and those are, things like treating the depression, correcting the sensory loss, getting them the hearing aids or the eyeglasses they need, reducing the anticholinergic burden. So, everyone and their mother basically is using Benadryl for something in some way, and that's super problematic in terms of the main neurotransmitter that we use in our basically from our chin up is acetylcholine. And that medication, if we're using medications that block that, using Benadryl, for example, to help us sleep, or for nausea, or whatever, or itching, or whatever it might be, again, just kind of ragging on Benadryl here as just kind of the remedy that we all grew up taking. I think we'll let me finish the thought. So blocking that can create confusion. It increases risk of falls, constipation, urinary retention, kind of your vision gets impacted, kind of all these problems just for that one drug that everyone kind of buys over the counter that we think is just so safe. So exercise and mobility preservation. Oh, my thought on Benadryl, sorry. More and more growing literature is, I think we'll find in the next 10 years or so, we'll probably find that Benadryl is not used as often. It may not even be available over the counter in terms of just recognizing how harmful it can be and not very beneficial. There's just so many better options than that. And that's just one example of one medication that could be potentially harmful. Caregiver support, advanced care planning, safety planning, other things that can actually be, helpful and beneficial. Another question was asked is like kind of prognostication in terms of what are we talking about here? How long are we talking about, or what is the journey of this going to look like? Is kind of a natural question that comes next. And ultimately, this is kind of a busy slide. I apologize, but I feel like just kind of laying it all out there quick is the easiest thing here. But ultimately, just looking at this kind of median survival component, just look and you can see there's just really this pretty much common theme here that it's like likely somewhere going to be on the order of 6 to 7 years, 6 to 8 years is kind of this thing. Alzheimer's, again, it's very slow early with this very long tail. There is an earlier variant that some people can get that's a little bit more aggressive. There is vascular dementia, which is usually a lot of cardiovascular components along with it, things like strokes and heart attacks. It's a stepwise kind of each time they have another incident, there's kind of this bigger drop. Lewy body dementia and Parkinson's disease, these often get confused. Ultimately, Parkinson's disease is where you start with the motor deficits first, and then you get cognitive impairment later, whereas Lewy body dementia, you start with cognitive impairment, and then later you're getting some of those movement disorders. So it's kind of how that works. And so frontotemporal dementia is kind of the real rough one, where it's like a lot younger, a lot of kind of executive function losses. I don't know if you ever heard of Phineas P. Gage, but a really interesting story there where a gentleman who works on the railroad kind of basically took a railroad tie type device kind of through the front of his head, totally scrambled who he was, and he became a very aggressive, didn't think of others, kind of lost his ability of his executive function, and just kind of a huge personality change there. But I think ultimately the biggest takeaway I would say is that what we're really pushing these days is kind of more the idea that there's likely not just one single type of cognitive impairment going on. It's likely a mixed component, and this is kind of really what's likely impacting most people. Prolonging life versus prolonging suffering. Again, just kind of what is the goal? What are we talking about if we're going to be on this journey for 5, 6, 7, 8 years? I think important to note that most of these folks who have cognitive impairment, they don't really die as a result of the cognitive impairment component. It's not like the brain just stops working, they go to sleep and they don't wake up. It's all the other sequelae of things that can happen. They developing dysphagia, they're having falls, they're getting infections, they're needing so much medication to manage behaviors that there's kind of an impact there. And so really just the mitigation of all those things, and being on that journey and talking about those things early as opposed to late. I had seen some other presentations here before about this palliative care idea and what the heck is it? Lots of conversations around it, and it, it's easy to get confused because we do lots of different things. And so ultimately, palliative care is just kind of the idea of symptom management, goals of care conversations, working alongside, lots of benefits to reduce conflict and all sorts of problems along that way. Driving. So, wow, this driving component, how do we get dad to stop driving or mom to stop driving? There's this idea of just take the keys or just take the battery, unplug the battery or whatever it might be. But there's a lot of, that is driving is our number one, I think, for most people, kind of source of independence. I could get up, I could leave here, I could drive away right now, I could be gone out of this situation. And when that becomes unsafe, you really have to, be really careful because it can hurt someone, right? A car can be just as dangerous as a bullet in a lot of scenarios and situations, in terms of there's a large mass kind of moving towards objects in an unsafe manner. Um, so when the visual components, the functional status, the physical cognitive impairments, I think the number one thing I always tell people is, would you, this kind of litmus test is, would you be willing to ride in the back of the car with your loved one? A lot of people like, I'd ride in front where I could grab the wheel or I could slam on the brakes or I could do something. But, if you wouldn't ride in the back of the car where you've got absolute loss of any sort of control of the situation, and the answer of that is a no, you probably really need to be evaluating if they should be driving safely. And so there's a form that we can use through the Idaho Department of Motor Vehicles that you can report these things. You need to be aware that is a part of public record. And so if you have your name and it's your dad and he reads that form, and he's going to be mad if your name is on that, you're reporting it. So maybe, eliciting some neighbors or some other person, you could say like, hey, will you fill this form out for me? So that when dad gets this, it's some random person he doesn't know. There are different resources in the community through neuropsych testing that they can kind of do simulated driving and sit through a battery of tests, kind of cognitive impairment, to kind of really assess their safety, both in kind of the classroom type of scenario situation and also kind of real driving situations. And ultimately, I'd point people who are just really stuck and not knowing where to start is this Negotiate. This is a kind of a website, I believe it's through Northwestern, but ultimately going through conflict resolution and helping people as we age negotiate. So if independence and going where you want when you want is the priority, then I'll take you, dad, or I'll do it. And so you kind of take away that one driving force of like why they're making the decision. And you can slowly peel back to get to the place of like providing them with answers and resources so that they are not needing and feeling like they have to drive. So end of life choices, as we're kind of exploring and navigating this thing, everyone says, just take me out back, or take me out back behind the woodshed, or take me to the forest. Like, just exceedingly unrealistic. Everyone talks about this, the plan. And I have seen it kind of actually taken place, or heard of it taking place, where there's some sort of situation like that. Probably 3 times out of the probably 100,000 people, that I've been around as a part of dying or helped navigate, or the people I talk to and in the circles I kind of work in, it just isn't really a plan. So you got to push past that initial wall and find out other things. The reality is lots of hospitalizations, hospice can be an option. Death with dignity was a question that someone had. How does that work? Voluntary cessation of eating and drinking was another question. So kind of real quickly, we'll run through some of those. Hospice, again, the biggest takeaway is that hospice is a philosophy of care, and it's also an insurance benefit. So anytime you try and take a philosophy and turn it into black and white, you have lots of kind of conflict there. But ultimately, a big picture, prognosis less than 6 months. And when you're ready to focus on quality over quantity, and you don't really want to go to the hospital to fix things, that's when it's probably right for you. It's a holistic, multidisciplinary approach to bringing the care to where the patient lives, whether that's home, facility, park bench, in their car, in the hospital, wherever they might be. And so a lot of nuances there. We could talk about hospice for days in terms of all the kind of components to it, but those are the big picture things. And I would just ultimately say that the earlier you get them involved, the better the outcomes in terms of caregiver burnout, symptom management, perception of quality of care, pain management, all of these things. And so there's tons of benefits for hospice. Very rarely does anyone say, I did it too soon. Almost everyone says, I wish I had done it sooner. So just kind of keep that in mind. So VSET is a thing some of you may or may not have heard about before, but it's this concept that we all basically have the ability to choose if we want to eat and drink, and no one can take that away from us. We can't force people to eat and drink. The one exception might be in components of like anorexia, where there's like a clear mood disorder that's impacting those people. But ultimately, in a person with capacity without some sort of mood disorder, that's kind of a patient's decision to eat and drink. No one can kind of impact that. And so it's done with an intent to end their present or imminent kind of suffering that they might be having. This is legal in all 50 states. There's no component where it's illegal. It's a lot of there's definitely some ethical dilemmas kind of been built in here for sure, but through talking about it in conversations with your healthcare provider, if that's something you're interested in or your loved ones expressing, interest, you can always kind of talk about it. What it's not is it's not suicide, it's not euthanasia, it's not physician-assisted suicide. It's ultimately, the distinct thing from starvation or disease or neglect or anything like that. It's kind of the person actually driving that. There's a fantastic resource, a whole packet with just a ton of things that kind of you can think about and elements, kind of contracts through this End of Life Washington, and they have this whole packet. And basically everyone has, again, kind of the ethical components of this. We have the right of bodily autonomy. It's equivalent to refusing any other medical treatment in terms of a feeding tube or CPR, any of those things. And there's a lot of ethical frameworks that say it's okay if you want to make that decision. You have the capacity kind of to do so. There's no one forcing you to be here or to live a particular way. So kind of just an interesting way out, if that's what you're looking for. Death with dignity, certainly a sort of a parallel here. Ultimately, when kind of identifying, there's in Idaho, we have a lot of states that we basically are surrounded, that it's legal. When we look at the population of the country, only 26% of people have access to this. There's a lot of kind of rules and residency components that used to exist that are now different. You no longer have to be a resident, for example, in Oregon to get access to this. In some instances, you don't have to request 2 weeks apart any longer. There's kind of lots of things that make this accessible now to Idahoans, and it'd be really important for kind of all of us to be familiar. You do need to have obviously kind of multiple clinician contacts. And so, continuing on the kind of the medical component again of what death with dignity is, you basically have to be able to get yourself to Oregon. You have to have kind of the resources or insurance to kind of access these things. But ultimately, if you have a terminal prognosis, you have 6 months or less to live, and you don't want to just sit around and suffer for that remaining time that you have left, you ultimately can, choose to kind of undergo this. Again, assuming you have capacity, it's not considered suicide or euthanasia. Certainly lots of legal considerations. For example, life insurance cannot deny you benefits. If your doctor doesn't want to do it or doesn't believe in it, they are allowed to object, but obviously have to refer you to get that access to that care. And again, the ethical considerations, autonomy, beneficence, non-malfeasance, and justice, and kind of all of those things. Again, ethical parallels of, terminal extubation. Is that euthanasia? Palliative sedation, is that euthanasia? Deactivating pacemakers, stopping nutrition and hydration in someone who doesn't have quality of life, or there's a lot of things that are really similar to these ideas that we use in common kind of framework. And so it's definitely something that many people kind of believe is a really important right. And so again, I want to kind of finish on time here. So sorry, I'm moving this forward a little quickly, but happy to take a few questions. But ultimately, lots of challenges, certainly. Early conversations, planning can reduce crisis and conflict. Collaboration with your team, with your family, your doctors, the places where you live, your community, kind of all of these things and ultimately, hopeful that these better questions or this better information can ultimately lead to planning and alignment and improved outcomes. And we're not kind of forcing our parents to do things they otherwise wouldn't do, and or they and their kind of not right mind are asking for things that they never would have wanted. And so the earlier you can have these conversations, ultimately, kind of the better it can feel. It can feel really awful when you're the one that's having to guess what they might want. Again, because we have what we would want, for our loved one, and then they have what they would want for themselves, and it's really hard to discern those things when there's a crisis and there's a lot of emotion and love involved. So I'll end there. Thank you so much. Again, happy to take any questions, but also realize we're a little bit short on time.
I can ask a question that I was looking at when you mentioned engaging the person who is experiencing the cognitive decline while they still can have these conversations. Are there any best practices that or considerations that people should give to these conversations before having them?
Best practices. Good question. I think that it's it ultimately is just, it's like shared decision making, I think, ultimately, and recognizing this is something that we as doctors struggle with, and we as parents struggle with, or we as children trying to become our parents for our parents, is that there's they are the experts on them, and you're not the expert on them. You might think that you are, but if they have some ability, there's the golden rule, which is treating them how they want to be treated. Excuse me, the golden rule is treating them how you want to be treated. The platinum rule being them being treated how they want to be treated. And so everyone is they're gonna respond to different approaches. Some maybe would respond to a strong hand. Others, you're going to be in a fight if you're trying to lead them to the water, because they're just not going to drink. And so the best practices, I think, is to have, just like with cultural competency or cultural humility, of like open, honest kind of curiosity around what is happening and exploring these things. Because early on, when they have enough insight to recognize, they have enough insight to recognize they're an adult with independence and autonomy, but they don't have the insight to recognize it's creating problems. And so just ultimately approaching them in the least threatening manner, but you have to be persistent. And if you're running into to kind of walls, using and reaching out to the Alzheimer's Association folks and looking at those resources, reviewing with palliative care, and maybe moving yourself as the person who's having to ask those hard questions, and letting someone be like a third party mediator to kind of ask those hard questions and point out those obvious, blatant violations of safety or risk that they're taking on. And so I wouldn't say at this juncture that there's like a best practice other than like keep your head up, keep at it, and like try and not create an enemy with them as you're doing it, because that's obviously not productive and people dig in.
Looks like Karen Midlow may have a question.
Dr. Gallagher, you mentioned about Benadryl. Is there a website that you could recommend for other medications that are harmful for seniors that we can access? Is there a best place to go?
Yeah, there's a resource called the Beers List, and it's spelled just like it sounds, Beers. And it's if you Google search geriatric Beers List, you basically, when you look at that, be prepared to be really kind of disheartened, in the sense that like almost every medication is on there that can impact geriatric folks, but it is again a spectrum of risk in terms of like what are the real bad players and what are the ones that are probably okay in moderation, but not wanting to mix A with B and B with C. And so the Beers List is kind of a great resource to start out there in regards to the geriatric patients and those medications to avoid.